Welcome to the deep dive.
Great to be here.
Today we're jumping into a stack of revision notes focused on a medical condition that's, well, thankfully rare, but absolutely critical to recognize, brain abscess.
Definitely critical.
These notes we've got cover, pretty much everything from what it is, what causes it, how it develops, and really importantly, how we find it and treat it. So our mission in this deep dive is to take all this detailed info and sort of pull out the highest yield points, the stuff you really need to know, maybe to solidify your understanding, or if you're tackling exams like the MSRA.
Yeah, nail down the essentials. Think of it as a guided tour through the must-know facts.
Exactly. Think of this as your guided tour. Okay, let's unpack this.
It's definitely a topic where knowing the key signs, the risk factors, it can really make a life or death difference. And these notes, they provide a really solid foundation for that, guiding us through the whole picture.
Absolutely. So let's start with the very basics. What is a brain abscess at its core, according to these notes?
Simply put, it's a localized collection of pus, and it forms within the actual brain tissue itself.
Okay, pus in the brain tissue.
Yeah. And it's almost always caused by some kind of infection, usually bacterial, sometimes fungal. The absolute critical takeaway from the definition is that it requires urgent medical intervention, like right away. This isn't something you wait on.
Urgent is key. And the notes highlight a few things that just underscore how serious this is.
Right. They explicitly call it potentially life-threatening. And a significant point they make is that it's often associated with polymicrobial infections.
Polymicrobial?
Yeah.
Meaning multiple bugs.
Exactly, yeah. By that, the notes mean you're typically dealing with multiple different types of bacteria, or sometimes bacteria and fungi, all contributing to the infection. It's also part of a kind of broader group of infections inside the skull, like subdural or extradural empyemas, but our focus today is specifically the abscess within the brain tissue.
Got it. Pus inside the brain. So where do these infection-causing bugs actually come from? What's the etiology here?
The notes give us the main culprits. On the bacterial side, the common offenders include things like Staph aureus, various Strep species, Bacteroides, Listeria. Those are some big ones.
Yeah.
For fungal causes, especially, if someone has a weakened immune system, Aspergillus, Candida, and Cryptococcus are important to remember.
And the notes mentioned it's not just bacteria and fungi, which I thought was interesting.
No, that's right. Protozoa can be involved too, particularly Toxoplasma gondii, which is highly relevant in immunocompromised patients, like those with HIV.
Ah, toxo. Yeah.
And other less common ones mentioned in the notes include things like Entamoeba histolytica, Trypanosoma cruzi, Schistosoma species, and just to add a slightly more unusual one mentioned, very rarely you might see it caused by helminths, like Taenia solium, that's the tapeworm.
Wow, tapeworm. That's quite a fact from the notes. So how do these various bugs actually get to the brain?
The notes describe two main routes. One is spreading through the bloodstream haematogenous spread from an infection somewhere else in the body.
Like where?
This could be from conditions like cyanotic congenital heart disease. That's a classic link, especially in kids. Or endocarditis, maybe even bad dental infections like caries.
Okay, so bloodborne. What's the other way?
The other major route is direct spread from infections that are right next door to the brain. So think chronic ear infections, otitismedia,
Right.
sinus infections, sinusitis, or dental abscesses sort of spreading upwards.
So that really bad sinus infection someone might ignore could, in a rare situation, actually track inwards, puts those common things in a different light.
It certainly does. And a really key point the notes highlight is that in a significant percentage of cases, maybe about 20%, you just can't identify the original source of the infection.
20%. Wow.
Yeah, that can make figuring out the underlying cause quite tricky sometimes.
That's a big chunk with no clear origin. Which leads us perfectly into risk factors who is more likely to get a brain abscess. If you see a patient with these factors, the alarm bell should maybe ring a bit louder if certain symptoms appear.
Definitely. And the notes provide a pretty clear list that helps us identify these patients. The big buckets are, 1, people with compromised immune systems. So HIV/AIDS or those on immunosuppressive medications, they're at much higher risk.
Makes sense.
2, chronic infections, especially infections around the head or face, like dental infections, sinusitis, otitis media. These give a direct pathway, potentially.
Okay, the local spread idea again.
Yeah. 3, trauma, or surgery. Any kind of head injury or surgical procedure involving the skull or brain can, directly introduce pathogens.
Direct entry.
And 4, some specific medical conditions. Cyanotic congenital heart disease is particularly noted, especially in children, as a source for that bloodborne spread we mentioned. Intravenous drug use is another risk factor, and recent neurosurgical procedures are also a clear risk.
So for revision, maybe think about those main categories: immune problems, local infections nearby, direct entry through trauma or surgery. Remember those specific high-yield links like cyanotic heart disease and Toxoplasma in HIV patients.
Exactly. Knowing those links helps you build that suspicion in the right patient context.
Okay, let's talk pathophysiology. How does this actually develop once the bug gets into the brain? The notes break it down into stages, which seems helpful for understanding the progression.
They do, and understanding the sequence is pretty important. First, the pathogens get into the brain tissue, either from, that adjacent infection or via the bloodstream.
Right.
The very initial stage is called cerebritis. You can think of this as the messy, sort of widespread inflammation stage. It's an area of edema, inflammation, but it's not yet a properly walled-off collection of pus.
So diffuse inflammation first, like a soggy, infected area. What happens next?
Then the body's immune system tries to contain it. This leads to the formation of a capsule around that inflamed area. It's basically an attempt to wall off the infection from the rest of the healthy brain tissue.
Like building a wall around the problem zone.
Kind of, yeah. And then inside that newly formed capsule, a well-defined cavity fills up with pus. This growing pocket of pus becomes a space-occupying lesion.
Meaning it takes up space it shouldn't.
Exactly. It starts taking up room and pushing on the surrounding brain. And this pressure is what causes many of the classic symptoms like neurological deficits and that dangerous increased intracranial pressure.
That clear progression from sort of diffuse inflammation, cerebritis, to a contained pus-filled cavity, that makes sense of why symptoms develop and often worsen over time.
Yeah.
Speaking of symptoms, what else could this be? The notes list some really crucial differential diagnoses.
Yeah, this list is vital because brain abscess symptoms can definitely overlap with other very serious conditions. The notes tell us to consider things like a brain tumor. A mass lesion can cause similar pressure effects and narrow deficits.
Okay.
Cerebral infarction, so a stroke, especially if symptoms come on acutely, stroke needs to be on the list.
Right.
Encephalitis, this is more widespread inflammation of the brain itself, often viral, which can present with fever and neurological changes too. And also metastatic brain lesions, cancer that has spread to the brain, can also present as space-occupying lesions.
And they specifically call out toxoplasmosis again here in the differentials.
Yes, absolutely. That's a key differential, particularly in immunocompromised patients, especially those with HIV, as Toxoplasma can form lesions in the brain that look quite similar to abscesses on scans. Remembering these alternatives is crucial for ordering the right tests and getting to the correct diagnosis quickly.
Okay, let's zoom out a bit then. How common is brain abscess? What do the notes tell us about the epidemiology?
Fortunately, it's relatively rare, particularly in developed countries. The notes estimate the incidence in the UK at around 0.4 to 0.9 cases per 100,000 people per year.
So pretty uncommon. Less than 1 case per 100,000.
Exactly. It does remain more common in the developing world. Within developed countries, like we touched on with the risk factors, it's seen a bit more often in males and, critically, in those people with the underlying risk factors we just discussed.
Right, it's not evenly distributed.
Not at all. And the notes also make an interesting point. There's been a decrease in incidence in young children, which is thought to be largely due to the widespread Haemophilus influenza type B vaccine, the Heba vaccine.
Because Hib meningitis could lead to complications like abscesses.
Exactly. Preventing that primary infection reduced one pathway. What's fascinating here is really how those specific public health measures, like vaccination and those underlying vulnerabilities, really shape the picture of who gets this relatively rare condition. It's definitely not random.
Yeah, it really highlights the link between systemic health, public health, and these localized infections. Okay, here's where it gets really interesting. What does a patient with a brain abscess actually look like clinically? What are the symptoms and signs we should be alert for?
The notes give us a sort of classic presentation, though it can definitely vary. A persistent, often dull headache is very common.
Okay.
Fever is also typical, though the notes specifically state it's not usually the dramatic swinging fever you might expect with abscesses elsewhere in the body, like, say, a liver abscess.
That's a really important distinction, isn't it?
Yes.
A high yield point for exams, maybe. Not necessarily a high swinging fever.
It is, yeah. Good point to remember. Other key symptoms include changes in mental state, like drowsiness, maybe confusion. You often see focal neurological deficits,
Well, neat.
meaning problems affecting a specific part of the body or brain function, like weakness in one arm, difficulty speaking, vision problems. It really depends on where the abscess is located in the brain.
Location.
Pretty much. Seizures, often grand mal seizures, can occur, and signs of increased pressure inside the skull, like nausea and vomiting, and sometimes neck stiffness or neutral rigidity.
And the notes mention a really concerning sign,
Yeah.
something to be really worried about.
Yes, absolutely. Be on high alert for a sudden dramatic worsening of the headache combined with signs of meningism, that's significant neck stiffness, maybe photophobia, sensitivity to light. This could signal that the abscess has ruptured, often into the ventricles, the fluid spaces in the brain, and that is a dire medical emergency with a very high mortality rate.
Okay, so symptoms are often a bit nonspecific initially,
Hmm.
maybe headache, bit of fever, feeling unwell. But the combination, especially with those focal signs or signs of raised pressure, should really raise red flags. What about things we might find on examination?
Right. On examination, you're actively looking for those focal motor or sensory deficits that might correlate with the likely location of the abscess. Critically, you're looking for signs of raised intracranial pressure, ICP.
Like what specifically?
While the notes mention Cushing's reflex or Cushing's triad, that's a classic, although often late, sign of significant ICP and brainstem compromise. It's a pattern of raised blood pressure combined with a slow heart rate and sometimes irregular breathing. You might also see papilledema on fundoscopy, that's swelling of the optic disc visible at the back of the eye.
Need to look in the eyes then.
Definitely. Depending on the location, patients might have ataxia, which is problems with coordination and balance, or they might be clearly confused or drowsy. In infants, remember, a bulging fontanelle is a key sign of raised ICP.
So the clinical picture is this mix of general signs like headache and maybe a low-grade fever combined with specific neurological signs pointing to a problem area in the brain and those dangerous signs of pressure buildup. How do we actually confirm this diagnosis? What investigations are essential?
Neuroimaging is absolutely the cornerstone of diagnosis. You need a scan. The notes specify using either a CT or an MRI.
Which one is usually the first step, say, in an emergency setting?
The notes highlight that CT scanning is often the preferred initial choice, especially in the acute setting, probably because it's faster and generally more readily available.
What does it show?
On a CT, the notes describe typically seeing a radiolucent area that's the low-density pus or fluid in the center surrounded by what's called ring enhancement. This ring shows up nicely after you give intravenous contrast dye because the capsule the body has formed takes up the dye.
Okay, so CT is fast and shows that classic ring. What about MRI? What does it add?
Well, MRI offers greater detail and better soft tissue contrast. The notes point out it's better at detecting maybe earlier stages, like cerebritis before a full capsule forms, or smaller satellite lesions, little daughter abscesses that might be nearby.
Okay, so this raises an important point for revision. CT is often your rapid first-line scan, shows the classic ring enhancement. But MRI gives you that higher resolution picture, perhaps better for subtle findings or really defining the extent. Need to know both.
Exactly. Knowing when each might be most useful is key. Other investigations mentioned include lumbar puncture to analyze the CSF, but the notes caution this is potentially risky if there are clear signs of raised ICP or large mass lesion because it could precipitate brain herniation.
Right. Need to be careful with LPs here.
Very careful. Routine blood tests like a full blood count, inflammatory markers such as CRP or ESR, and importantly, blood cultures are also needed. You want to look for signs of systemic infection and maybe identify the organism if it's in the blood.
And to find out which specific bug is causing the abscess itself.
Yeah. The gold standard for identifying the specific organism is aspiration of the pus from the abscess itself, usually done surgically or stereotactically. You send that pus for microscopy, culture, and sensitivity testing. Sometimes, if aspiration isn't feasible or doesn't give an answer, a biopsy of the brain lesion might be necessary.
Okay, so we've managed to diagnose a brain abscess. How do we manage this? What's the treatment approach, according to the notes?
Management needs to be aggressive, and it's multi-pronged. It involves immediate empirical antibiotic therapy, starting broad-spectrum antibiotics right away to cover the likely pathogens before you even know the exact bug.
Okay, antibiotics first.
Often, yes. And frequently, surgical drainage or aspiration of the abscess is necessary. This helps remove the bulk of the pus and crucially reduces the pressure inside the head.
Makes sense. Get the pus out.
Yeah. And you absolutely must manage or eliminate the underlying infection source if one has been identified. Treat the sinusitis, the ear infection, the dental problem.
Don't forget the source.
Never. And providing good supportive care is vital. Things like controlling symptoms, managing ICP if it's raised, controlling seizures if they occur. Finally, rehabilitation might be needed down the line if the patient has lasting neurological deficits.
Can you give us a bit more detail on the surgical and antibiotic parts based on the notes?
Sure. The notes describe surgical options, including aspiration through a burr hole, which is making a small hole in the skull, less invasive, or sometimes a formal craniotomy might be needed for larger, more complex, or deeper abscesses. If it's an empyema, a collection outside the brain tissue but inside the skull, surgical evacuation is usually required.
And the antibiotics. What combination do they suggest starting with?
For the initial intravenous antibiotics, the notes specifically recommend a combination, usually a third-generation cephalosporin like cefotaxime, plus metronidazole.
And that combination empirically targets a broad range of bugs.
Yes, the cephalosporin covers many common gram-positive and gram-negative bacteria, and the metronidazole adds crucial coverage for anaerobic bacteria, which are often involved, especially if the source is suspected to be from the mouth, sinuses, or ears.
Got it. Broad cover initially.
Exactly. Then you tailor it once you get culture results back, if possible. Management of raised ICP might involve medications like dexamethasone, a steroid, although its use is sometimes debated as it can reduce antibiotic penetration. Anticonvulsants are used if the patient has had seizures or if the abscess location puts them at high risk. And again, really important, find and treat that original source. Don't just treat the abscess in isolation.
So it's very much a combined medical and often surgical emergency. What's the outlook for someone treated for a brain abscess? What does the prognosis look like based on these notes?
Well, the prognosis varies significantly. It really depends on several factors listed in the notes. Things like the size and location of the abscess, the specific bug causing it, the patient's immune status, and crucially, how quickly treatment is started.
So timely diagnosis and getting that management started fast are key to a better outcome.
Absolutely critical. The notes state that with prompt management, including surgical drainage if needed and appropriate antibiotics, the prognosis is much more favorable. However, delays or inadequate treatment can lead to permanent brain damage, lasting neurological deficits, or, sadly, death.
What are the mortality figures like? Do the notes give a range?
According to these notes, the mortality rate ranges somewhere between 17% and 32%, which is still quite high, even with modern treatment.
Yeah, that's significant.
It's generally higher in patients who are immunocompromised or those who present in a very poor neurological state, maybe comatose, measured by a low Glasgow coma score, GCS, right from the beginning.
So that initial neurological state is a strong predictor of how things might go.
Yes, the notes emphasize that the patient's neurological condition before treatment starts is a very significant predictor of their eventual outcome. They also mention that deep-seated infections, or those in certain critical brain areas, tend to have a worse outcome, partly because there's a higher risk of them rupturing into the ventricular system.
Which brings us neatly to the complications. What are the long-term issues or the immediate dangers, even if the abscess is treated successfully?
Even after the infection itself is cleared, patients can unfortunately be left with lasting problems. Neurological deficits and permanent brain damage are significant risks.
Like weakness or speech problems.
Exactly. Things like hemiparesis and epilepsy or recurrent seizures are particularly common long-term complications, especially, the notes point out, if the abscess was located in the temporal lobe.
How common is epilepsy after that?
The notes give a frequency of 30–50% for developing epilepsy in that specific scenario. That's a really high percentage to remember.
Wow, yeah, up to half of those patients.
It's a huge risk. Other serious complications include persistent increased intracranial pressure and the risk of the infection spreading. If an intracerebral abscess ruptures into the brain's ventricular system, those fluid-filled spaces, it causes ventriculitis. That's a severe inflammation with a very high mortality rate.
A devastating complication.
Truly. And for survivors, the notes indicate they can experience long-term neurological problems, sometimes called sequelae. These can include things like that hemiparesis we mentioned, weakness or paralysis on one side of the body, or visual field loss. The percentage of survivors with these lasting issues varies quite widely in the literature, maybe 20% up to even 80% in some series, again, heavily influenced by how quickly and effectively that initial infection was treated.
So if we connect all this to the bigger picture, Understanding the signs, knowing the risk factors, and intervening rapidly isn't just about, preventing death.
Yeah.
It's absolutely critical for minimizing those devastating long-term neurological issues and really trying to improve a survivor's quality of life afterwards. Every hour truly seems to matter here.
It absolutely underscores the need for vigilance in recognizing this condition early.
Okay, so we've taken a real deep dive through these revision notes. We've covered the definition pus in the brain, the surprising range of causes, from common bacteria to, well, tapeworms occasionally. Who's most at risk? How it progresses from that initial inflammation, cerebritis, to a walled-off pus pocket. What else it might look like, those differentials. How common it is or isn't. What symptoms and signs to look for. How we investigate, especially with imaging like CT and MRI and getting cultures. The crucial steps in management antibiotics, often surgery, treating the source, and finally the potential outcomes, the prognosis, and those serious complications.
Yeah, having that framework really helps connect the dots when you encounter a potential case or when you're revising.
Absolutely. Understanding these points in this structured, hopefully high-yield way is really invaluable for revision and just for being prepared in a clinical setting.
Yeah.
So what does this all mean in the end? Brain abscess, though uncommon, is a true medical emergency. It's often linked to identifiable risks. It requires rapid suspicion, confirmed by specific imaging, and needs aggressive, often surgical management alongside tailored antibiotics. And the goal is always preventing not just death, but also that severe, lasting neurological damage. So here's a final thought to leave you with, something based on everything we've discussed from these notes. Given the relatively high mortality rate, even with treatment, and the significant chance of long-term disability for survivors, maybe 30–50% getting epilepsy if it's temporal lobe, for instance, how does focusing on recognizing those early, sometimes even subtle signs, empower us? How does it change the way we approach patients who might have risk factors, but maybe only vague symptoms initially? It's something to really consider as you solidify this knowledge.
A very important question to carry forward into practice.
For more resources to help with your revision, do check out MSRA.com.
And for loads of free practice questions, you can visit freemsray.com.